Thank you, Hein. Thank you, everyone, for giving me this opportunity to yet again address you. I hope that from this presentation we can flow on or continue a discussion. For those of you who have heard me speak before, you will know that I'm very fond of telling stories or sharing anecdotes. You see that the anecdote can give you the individual impression from a population sample that we draw our epidemiological studies from. Look, the anecdote can be the face of the individual and the myriad of data points that makes up the Bell distribution curve of statistical results. And when you look at that photo, you will know that it's very unlikely that I'll become the poster boy for work-related stress. It's even more unlikely that I will be to work-related stress what John Kirwan is to depression. But what the epidemiological data tells us is very clear, and I don't need to repeat this. And I actually wondered whether Hein had actually hacked my presentation. We haven't each other at all about this issue. But I guess the fact that so many people are talking about it in the one Congress just tells you how important it is. Many studies, both nationally and internationally, repeatedly show that work-related stress is very prevalent. Both in New Zealand and elsewhere, more than 50% of doctors suffer from stress and burnout. In a study published in JAMA not so long ago, it was found that 87% of US doctors face stress, which is beyond what is productive at work. And even more recently, from the Royal Medical Benevolent Fund, a study of specialists showed that more than 2/3 of those working in the field would not recommend their children to study medicine. That is a sad indictment of our profession. So now going back to the individual anecdote. I had an experience last year. It's a little bit confronting for me to share this with you today, but it's a good, maybe, conversation starter. After what wasn't a particularly unusual day at work, I went home for dinner. I sat down with my family and kids. And partway through the dinner, I started feeling slightly odd and unusual. And the next thing is I got a bit of a funny sensation on the side of my cheek, and I had a funny tingling in my hand. My son starts laughing when I'm drinking my wine, and wine is dribbling down my face. Now, those of you who heard me speak 3 years ago, you would have heard about my experience of Bell's palsy in the US, when I got paralyzed on the other side of my face. And I thought, crap, how lucky am I? I'm getting Bell's palsy on the other side. But as the dinner progressed, the funny feeling got worse. I had trouble moving my arm, and I thought, this is beyond Bell's palsy. My kids laughing, it wasn't so humorous anymore. There was definitely some nervousness there. So I took myself downstairs to my room, and with some difficulty I walked down the stairs. And as I lay in bed, things began to progress really quickly. Before I knew it, I couldn't move my left arm or my left leg at all. And I was very lucid, and I thought, crap, I'm having a stroke. And it seemed really unfair, but that's got nothing to do with it. My wife walked down the stairs, she took one look at me, and she went fairly hysterical, which even for a Spanish woman is unusual. And I knew at that point that things were, really bad. I also knew, even though I had this lucid thinking process, that I would not be able to speak. And I opened my mouth and nothing came out. So my wife called 111. And I was so aware of everything that I couldn't do anything. What I wanted to say to my wife is, take me directly to ED. I thought I was having an embolic stroke. And I thought if I got TPA, maybe that will help the disease process. That's what I thought, at least as a psychiatrist. But I couldn't convey that to my wife. So she got through to 111, and I could still hear the operator on the other side of the line. These are highly trained people. They speak softly to calm the situation. And she said, "Madam, can you describe your husband?" And she goes, "Even for him, he looks really odd. He's not moving his left side, and his face looks even more awful than usual." "Madam," she says, "can you please ask your husband to smile?" Now let's think about this. Are you a neurologist? Any neurologists here? Any neurologists? Any emergency doctors? Please put your hand up. Go on, don't be shy. What is wrong with you people? Telling somebody who either is having or may having a stroke And then asking them to laugh? That's stupid, isn't it? Laugh, you're having a stroke. Imagine if the rest of medicine had followed suit. What would happen if you'd be having a heart attack? Sorry, my husband's got this crushing central chest pain, and the cardiologist says, can you ask him to run a marathon? Or the urologist. That'd be a good one. Doctor, I've just got this real problem passing urine. I've got all this hesitancy. And lately, I think I've got into urinary retention. I think managers would love this one. What would the urologist say if they followed suit of the neurologist? The urologist might say, piss off. In a strictly medical way, I guess. So look, all jokes aside, my stroke symptoms were progressing pretty quickly. And every time I spoke, I could just hear, That's all I could say. An extraordinary experience. So I thought, well, what can I do? I can't communicate with my wife. So I just thought I'd just lie back and go for the ride. Just try to relax. The ambulance arrived. They got down the stairs. They put me in the little stretcher. And then as they were taking me up the stairs, my 8-year-old boy went running up into my study and hid. And he said, I love Papa. I love Papa. And he was so distressed. And this is what we have to remember. The stress that affects us at work not only takes a toll on us as individuals, but it also exacts a price from our families. And that's probably what weighs the strongest on me, the heaviest, is that this had a very significant effect on my wife and kids. By the time I got to ED, a lot of the problems were largely resolved. I felt like a bit of a fraud. They did a whole battery of tests. I got sent off for my brain CT, I had ECG, any countless of blood tests. And in the end, I made almost a full recovery with a little bit of facial asymmetry. And the ED doctor thought I either had a TIA or a migraine with neurological symptoms. After ED, for the next few months, I can tell you I was left with more than a lingering fear that I might have another TIA or a stroke. 3 to 6 months after a TIA is a risky time. After all the tests had done, there's one thing that stood out, that they found that I had these ectopic ventricular beats. And being a psychiatrist, I didn't know much about cardiology. And once I realized that my heart was doing funny things, I began focusing on my heart. And shit, every time there was a difficult situation, my heart will do all sorts of funny things. And I just spiraled into this increasingly difficult to manage situation. I'd be in meetings and I'd be checking my heartbeat, trying to look normal, and I'd be doing all sorts of funny things. And I'd be freaking out, but I'd still be at work trying to manage. I soon realized I had this tight knot and a feeling of nausea in my stomach. And this went on for months. And then over time I thought, well, how did I get to this? Yet I'm a robust, young, rugged male. How did I end up checking my pulse? I was literally a wreck. How did I get to this? You see, for months I'd been ignoring clear warning bells. In the months leading up to that TIA, I was having migraines, 3 to 4 migraines a week. I'd got used to working with migraines. My migraines don't have crushing headaches attached to them, but they have nausea, mild, dull headache. But I get these scintillating scotomas. And I got used to working with those. Don't know if any of you guys have. I got used to assessing patients, doing prison clinics when I could only partially see my patient in front of me. I gave evidence in the High Court, and this is what it looked like, trying to read my report. I had to memorize half my reports because I couldn't read them with scintillating scotomas. In a particular High Court trial, I had this aggressive defense lawyer who was cross-examining me really aggressively, and he looked to me like he was underwater. And you just get on with it, don't you? Hey, how's this for an inspirational statement from Mid-Central DHB? So what happens is over time, we either adapt or we accommodate, because we have to, because the work doesn't go away. And so we just tend to get on with it, and often it is to the damage of ourselves and the damage to our families. So through this whole process, I had to finally say to myself, hey, I'm really stressed. And I thought, me, really? I'm stressed? I thought I was the cool dude that had been climbing mountains for 30 years. One of my biases in life is to seek out real tough challenges. I've always sought stress and challenge. I've climbed in all the major mountain chains around the world, and I've loved it. I've coped really well with it. I've worked as a photojournalist in some troubled spots around the world. I spent months exploring in the jungle, including in one time getting lost for a week without eating anything, and that's me after losing about 20 kilos. See how resilient I am? I'm still juggling balls, even though I weigh hardly anything. I've been involved in search and rescue missions. I have brought down dead climbing partners from the mountain. And I've had some really tough days out on the adventure field. So how could it be that I had been in stressful situations, I had courted them out all my life, and here I was a wreck of a person? How did I get to this? Where did the balance of resilience and vulnerability go wrong for me? And nothing like having a TIA to make you self-reflective. You remember this guy? Bill Clinton? He won a second election by saying, it's the economy, stupid. And for me, it's the context, stupid. Ask any good forensic psychiatrist. Everything is in the context. And that's what's important for me. And this is the context that we're working under. We've already talked about this. Relative to GDP, health has been systematically underfunded for a long time. We've talked about $2.3 billion of health dollars being stripped from health over recent years. That occurs at the same time that the population grows, that there's more older people within the population, and our treatments are more costly. So we're under increasing pressure. As a forensic psychiatrist, look at what's happening to the prison population. Which is I can't get the laser pointer, but New Zealand's got the seventh highest incarceration rate in the OECD. Well ahead of Australia, and we all hear about Australian detention camps, but we, per capita, incarcerate 25% more people than they do in Australia. When I started in forensic psychiatry, just before 2000, the national prison population was sitting at around 4,500 people. Now, in 2016, the prison population is 10,600. It has more than doubled in the time that I have worked. Now, whilst you see this steep rise in the curve of the prison population, our resources have pretty much flatlined since here. There has been not a single additional forensic psychiatrist, not a single additional hospital bed to manage this growing population need. There has been markedly increased expectation from our services, so not only are we treating bigger numbers of people in prison with diminishing resources, but there is a growing government expectations as to what we will deliver within the prison system. We've been asked to do assessments for domestic violence, child abuse, all very important, but you can't just keep milking the dry old cow forever, can you? And medico-legally court-ordered reports have doubled in number in that time. And we're working in outdated facilities. Our facilities were built around 2000. They are really old now. It's really quite weird. Sometimes you go to work and you'd think it would be really difficult to get out the medium secure door. It's really difficult to shut them sometimes. You almost got to convince somebody and then say, push this door shut, please. Our facilities are really outdated. In the last 5 years, I've been involved in designing 3 potential new facilities, investing hundreds of hours of work, but not one of those facilities have been built. It's all been a stalling tactic. So remember, the prison population has more than doubled in the last 17 years. What about the prevalence of major mental illness within the custodial setting? And there are 2 really important studies that will inform us about this. There's a Phil Brinded and other colleagues study from 1999, and a more recent study from INDIG, from the Correction Services, conducted just last year. And what these studies are showing us is that the prison population have a very high rate of mental illness. 91% of people remanded or sentenced to custody have a lifetime diagnosis of a mental health or substance use disorder. 62% of males and 71% of females have those diagnoses in the previous 12 months. That's from the 2015 study. 2/3 or more have a lifetime diagnosis of a mental or substance use disorder. 31% had 2 or more of those diagnoses in the preceding 12 months. 35% of prisoners had ever thought of suicide. 17% of prisoners had ever made a suicide plan, and 19% had actually attempted suicide. The lifetime prevalence of psychotic symptoms within the custodial setting is doubled from 6 to 12% between the 1999 and the 2015 study. The prevalence of anxiety disorders has doubled or tripled in that time. Bipolar disorder has more than doubled between the 1999 and the 2015 study. And the prevalence of stimulant abuse and dependence in custody has increased from 4% in 1999 to 38% currently. So not only are we jailing more people than ever before, there's an insatiable appetite to detain people in custody, but we seem to be jailing more people with major mental illness of a very complex nature. And at the same time, we're not given any additional resources to manage that. Knowing this, in 2007, there was a national New Zealand prison screening tool studied. And the emphasis from corrections and the government is that given the high prevalence of mental disorder in custody, we would trial a new screening tool. And the purpose of the screening tool is to have a low rate of false negatives. But in order to achieve that, we knew that the screening tool, which was a combination of the best international tools, would have a very high false positive rate. And this was done in a very systematic, very scientifically validated way. And what the designers of the New Zealand prison tool, some of the best thinkers in forensic psychiatry in the country, warned the government and the funders is that if we implement this, which is the best tool, you would have 30% of prison receptions testing positive on the screen. 12% of those would require specialist care. 6% would require standard care, and 6% would require assertive care. A business case was made. And what the business case stated is, if you are going to introduce this prison screening tool, for which there was an enormous amount of political pressure, you have to increase the amount of resources and staff to manage that. It argued that we would require 16 full-time equivalent staff to manage the outcome of the New Zealand prison, the introduction of this tool. That's 12 additional staff to what we had. We would need 17 additional beds, 5 for women, 1 for youth, and 11 low secure beds. The prison screening tool was introduced by corrections under pressure from the government without any additional resources. And ever since then, all we've been doing is chasing our tail. The business case that was created in relation to additional resources is now 10 years out of date. And in that time, there's been a 33% further incrementation in people remanded to custody. Now, the extraordinary thing is, this sort of example, I'm sure, is repeated in all your departments. There has been an increasing expectation that we will deliver more and more and more care with less or no additional resource. It is extraordinary that in the lead up to the election, Jonathan Coleman refused to admit there was even a problem with the mental health system. He's quoted in February of last year as saying that this was of high quality and that people were misleading by claiming that there was so much unmet need. In an interview, Jonathan Coleman even refused to use the word problem in relation to mental health. It's extraordinary, isn't it? Now, for those of you who were here last year, you might remember the presentation of Samuel Akub, and he talked about the rise of post-truth rhetoric following the Trump election and the presidency of the United States. Well, in November last year, the Oxford Dictionary actually adopted a new word, which is called the post-truth. They actually called it the word of the year. So this is now a real word, which is in the Oxford Dictionary. And it means it's an adjective that refers to relating to or denoting circumstances in which objective facts are less influential in shaping public opinion than appeals to emotion and personal belief. And sadly, we have been dragged along behind this post-truth era. And that's where we sit now. So let's examine some of the post-truths from the previous government and just reflect these to the new government. So the previous government said there was no mental health crisis, and it's great to hear from the new minister now admitting that there may well be. There was also continuous allegations there was no underfunding of health. The new government is now accepting that there is. They also talked about no growth and unmet demand, that sugar taxes wouldn't work, and I have to have a go at this. They also said that the TPP would not raise the cost of medications, increase health inequality, and lead to loss of sovereignty. I still maintain that the new TPP is old wine in new bottles. And unless they get rid of the investor-state dispute settlement clauses out of it, which allows corporations to sue the government, they will disadvantage themselves in being able to regulate for healthy societies and to stop climate change. So the post-truths continue. And the most interesting post-truth is that the Canterbury Health Services is allegedly underperforming when the population-based formula for its funding is shown repeatedly to underrepresent the number of people living in Canterbury. How can it be that the Minister or the Ministry of Health says that the Canterbury Health Service is underperforming at the same time that the NHS wants to use it as a model to develop their own health service? It's even spoken of so highly in the King's Fund. So how did I get here? From TIAs to post-truths. We've already talked about stress and burnout. The context is important. You see, I was really surprised. I thought I would be well suited to the position of being a clinical director in a forensic service because I had such a lot of background experience in stressful situations, be they in sport, working as a photojournalist, search and rescue. But the context is important. And that's where a lot of us are really facing an uphill battle. The context is so difficult. Even when I climb a really, really difficult route, I feel like I've got more chance of success than I have in my current working environment. I have no control of what happens day to day. One of the things about high performance is you need to be able to focus on the task at hand. Just block everything else, focus, perform well. My life, as I'm sure many of yours is just constant distraction. I think today I'm going to achieve this, this, and the other thing. And I arrive at work and there's just any number of distractions. What are your KPIs doing? And we need to admit somebody and we don't have a bed and we need to prioritize this, we need to prioritize that. That sort of stress is destructive. It is not creative stress. It is the stress that a lot of us face. And take it from me, it eventually wears you out. The one thing that became obvious to me is that I had been wearing out to some extent for a long period of time, but I wasn't aware of it. And I'm aware that a lot of our colleagues are under far more stress than they realize, but they don't have an awareness of where that stress sits within them, probably until something regrettable happens with their own health, or they tip into mental illness, or they abuse alcohol, or the families fall apart, because remember, it's also the families that are affected by the stress that affects us individually. There is recognition of this now, and the World Medical Association has actually changed the Hippocratic Oath. And now you have to say, I will attend to my own health, well-being, and abilities in order to provide care of the highest standard. So the next time you're really stressed at work, and we know that stress affects your performance and you might be harming your patients, you're also breaching your Hippocratic Oath because you're not even looking after yourself. But perhaps the best example of how stress can affect you is this study on capuchin monkeys. I don't know if any of you guys have ever seen this. And it's a study of how monkeys react to stress which is beyond their control. And it's a very simple experiment. It's an experiment that looks at inequality and unfairness. So there's two monkeys side by side. And the perverse researchers decided that they would give the same task to both of the monkeys. But one of the monkeys would be rewarded with a cucumber, and the other one would be rewarded with a grape, no matter what they did. Now look at the response of the monkey to that.
First piece she eats, then she sees the other one get
There's a little delay, but it's coming.
So she gives a rock to us, that's the task, and we give her a piece of cucumber and she eats it. The other one needs to give a rock to us, and that's what she does. And she gets a grape, And she eats it. The other one sees that. She gives a rock to us now, gets again cucumber.
I'm that monkey on the left, by the way.
She tests a rock now against the wall. She needs to give it to us. And she gets cucumber again. So this is
So all jokes aside, I think in the right context, very robust people will be put in these untenable situations which will express themselves in these stressful conditions. We all know the effect of stress. We don't need any more research. We all know about the aberrations of the endocrine system. We all know that chronic stress, particularly in situations that you can't influence, is particularly noxious and toxic. We live in a post-truth era. I think that's well established now. I think the social contract is being broken because inequality in New Zealand has grown so much and there is so much unmet need and we're all chasing our tails trying to catch up with this. But no matter how hard you try, you're not going to get there. So if you work harder and harder and harder, you're not going to get anywhere when the numbers grow that large. When there's a doubling of the prison population and a doubling of mental illness within that population, you've got no additional resource to manage that. No matter how hard you work, you're not going to win. And that's stressful, that's destructive. As a group, we have to think again how we speak truth and facts to power. Because for the very best intentions of an incoming government, I think the task is going to be far more complex than the discussion this morning suggested. At an individual level, we have to be aware of stress at a personal level at a much earlier stage than what happened for me. I think we have to start having a discussion and normalizing this and seeing what we can do about it. Ultimately, though, we really have to refuse to accept cucumbers when we can expect to have grapes. Thank you very much.